Welcome, everyone. I'm Andrew Duckworth, and I'd like to thank you for joining us for our podcast for the month of August. We hope you're all keeping well as we hopefully are emerging to some degree out of the pandemic and our lives are starting to normalise somewhat. We also hope that you've enjoyed our podcast so far this year and that you're enjoying all the content from the knowledge translation team here at the BJJ, and that we're ultimately achieving our goal and aim of improving the accessibility and visibility of the studies we publish here at the journal. As part of this year, we're producing some special edition podcasts. The first series is Insights from the US, which the first podcast was recently released, and it was a great discussion with the brilliant Professor Heather Ballier, the president of the OTA in North America. The other special edition series is with our incredibly hardworking and invaluable specialty editors here at the journal. The aim of these is to give our listeners an insight into the vital work they do here, what they feel the current research trends are in their area, as well as highlighting some papers from the past year that we've published, which will be available for free temporarily after the podcast is released. We started these in March and have already heard from the brilliant specialty editors for knee, children's orthopedics and shoulder. And today I have the pleasure to welcome back Professor Matt Costa from Oxford to discuss the specialty area of trauma. Welcome back, Matt. It's great to have you with us, and thanks for taking the time to join us today.
Fantastic. Thanks for inviting me, Andrew.
So, Matt, if we look at the past 18 months, it's been a very strange and difficult time for all of us. Can you sort of give us a brief overview of your own insights, to a degree with regard to your own clinical practice, but more predominantly your role as a specialty editor for trauma here at the journal?
Sure, yeah. So from the clinical side, you're right. It's been very, very strange times. We actually did a podcast, it must be a year ago now, about the initial impact of the first sort of wave. And at that time, I actually did confess to being actually very lucky, which was a funny thing to say at that stage, because doing just trauma surgery and the trauma kept coming, whereas all my elective colleagues initially, all their wards were obviously closed during the first wave, and then most of them were actually redeployed to do other jobs and that. So being able to just carry on doing the day job as a trauma surgeon was actually quite a privilege compared to a lot of my colleagues who spent some fairly uncomfortable times on ITU with some very sick patients in a very unfamiliar environment. So from that side, I felt very lucky, and that's, of course, continued all the way through. And what's amazed me is how quickly the trauma has ramped back up to at least as busy as it was before, if not busier. I'm sure you've seen the same thing in Edinburgh. It's crazy busy at the moment. I think everyone's saved up their sporting injuries and Saturday night injuries and so on. And, of course, the major trauma and fragility fractures have kept coming as well. So it's been interesting times. But I do feel that certainly the atmosphere in the hospital it's almost back to normal. There's a usual sort of mild panic and pandemonium, but nothing like the height of the COVID, certainly first wave. So, yeah, hopefully, as you say, some light at the end of the tunnel.
Absolutely. I think we feel the same. It just seemed to have ramped up over the past couple of months, particularly. It's just the trauma really has just exploded. And like I say, I feel very lucky that we've managed to continue to do our day job and had that access. But like you say, I think the general feel is things are getting there, aren't they? It's not there, but getting there.
Sure, and it's going to, on the planned care side, obviously it's going to take a very long time to catch up with this enormous backlog. But yeah, as I say, from my perspective, the trauma just continues unabated.
Yeah, absolutely. And in terms of your role as specialty editor, how's that sort of, you have to adapt or change? What's been different over the past year to 18 months?
Sure. Well, I think that the biggest change has been the volume of papers coming through. I mean, I think a lot of trauma and orthopedic surgeons took the fact that they couldn't operate and do their day job as an opportunity to write up their paper they'd never got quite around to finishing and submit that to the journal. I think that's the same across most of the specialty sections of BJJ, and I've heard from other people involved in other journals that it's been the same there as well. So yeah, the volume of work coming through has been massive, and that's been great. I mean, to get increasingly very high quality papers coming through the trauma section is just a real pleasure for me to see on this side. The flip side of that is we're being pretty ruthless now about what we accept and what we don't. So I think even 5 years ago, papers that would have had a very good chance of getting into the Bone Joint Journal, big case series and so on, are just not getting a look in because of the sheer quality of the papers that are coming through now, which is fantastic. We're increasingly disappointing some authors who are writing good material, but it's just not quite at the level that we need for the journal these days, given the level of competition we've got. We can't publish everything, is the sad truth of the matter.
Absolutely. I suppose that's where the role of the BJO is coming a bit, isn't it? It's given us that sort of outlet for maybe those papers, like you say, 5 years ago, they're good papers, but just not at that methodological rigor that we're seeing increasingly, particularly in trauma, but in all the other sections. And the BJO has been a good outlet for that, hasn't it? And done really well from it, really.
Yeah, absolutely. And yeah, there's a lot of good material in there. And, sometimes there's not, people say, oh, is that a good enough? It's not, but it's a spectrum, and some things are very close. And sometimes it's, there's a little bit of luck involved, and a tailing wind, and a reviewer in a good mood. And, and so there's a lot of really good stuff in the BJJ. I think it's been a great outlet for those papers that are nearly there. And, the standard's still pretty high. I mean, a tiny fraction of what gets submitted actually gets through, even through the review process. So it's still great. And we certainly publish quite a lot of material in there.
Absolutely. And so last question about COVID. So sort of COVID-related trauma research, there's been obviously a lot published about that in various sort of areas. Do you think we need much more of that? Have we closed that book, or do we need some more information moving forward, do you think, so that as we sort of settle into a normal with COVID, I suppose, in inverted commas?
Yeah, so I guess there's sort of two elements to it. I think some of the papers, I mean, you were involved in some of those, looking at what the impact was of the pandemic, particularly the first wave, in terms of outcomes of patients coming in with COVID, with a hip fracture, unfortunately acquiring COVID in the hospital during the hip fracture, and even the outcomes of patients who are not, on a COVID-free pathway, if you like, but just the impact of the pandemic on the service provision. Yeah, that was really, I think, actually really helpful and really interesting. I think there were a whole series of Me Too papers which didn't really add a lot after the bigger work comes out, the sort of national and international studies there. And so I think a pause was probably quite sensible in terms of publishing more and more material. But I think there'll be some interesting long-term sort of effects on both the service, which will come out, particularly in planned care, but also in trauma and the way we deliver trauma, and move to much remote follow-up or reducing follow-up completely as a result of the pandemic, because patients don't want to come. They never particularly enjoy queuing up in the car park to get into the hospital anyway. But if you're queuing up and you're worried about COVID, or I think it's just now an appreciation that we don't have to go to hospital. So why would we want to? So I think there'll be long-term changes, and mapping those changes and reporting on the effects of those changes, I think, will be very interesting. But perhaps, in 2 years' time, or probably when the dust is properly settled, we'll be able to review that more clearly.
That's interesting. And in terms of sort of moving away from COVID then, what do you think have been the main themes sort of over the past year or two that you've seen coming out in trauma? What sort of areas of interest or areas of research that have been topical?
Yeah, I think the patients don't really change and the injuries don't change. It's fascinating, isn't it? You go to the big trauma meetings, and everyone's talking about the latest gizmo or technique and wants to tell you about it. But as we get sort of older, certainly as I get older, there's not that much really new that comes along. So, most of what we're doing is refining techniques. So there's not been step changes that I've seen in there. The biggest, in terms of the actual surgery, the really big changes have been in the way the pathways of care have altered, and how patients are being processed through systems in different countries around the world, and that's changing very rapidly. So I think for me, that's where the big changes have been, not necessarily in the techniques or the implants or the actual surgical bit, but the bigger questions about care pathways. I'm thinking in low middle income countries, we're seeing increasing evidence that multidisciplinary care, which is something we've kind of come to accept as normal, certainly in the UK, it's been gradually recognised, because it doesn't exist in many countries. It's still, for instance, for hip fractures, many patients are looked after solely by an orthopaedic team. And with the consequent problems of people dying, which we all remembered, and unfortunately the National Hip Fracture Database documented for us from a few years back, which are now much improved. Absolutely. So I think those to answer your question, I think the big change has not actually been in the surgery, but in the care pathways more generally.
That's interesting. And in terms of, just before we move on to the highlight papers, obviously we all know you're very heavily involved with sort of, not just acquiring grants, but on grant bodies. How do you think that's changed over the past 18 months? And do you think there's any long-term changes we're going to see because of that? Obviously, money's tight for the whole country. So how is it going to be different, do you think, moving forward for us?
So, I think it's a really good question. So for trauma research in the UK, if we're absolutely honest about it, there's only really the National Institute for Health Research, obviously the research arm of the NHS, that funds the big projects. There's other funders in the space, and AO, and there's arthritis occasionally, and some of the other smaller funding bodies do contribute useful research. But in terms of the big trials and big observational studies, it's really only in NIHR. And I think many of us were very worried that the NIHR budget, as along with all of the public sector funding, has taken a big hit. I think the UK response to the pandemic, particularly with regard to the vaccinations, has actually stood the research sector in good stead, in that the profile's never been higher. And so, fortunately, to a major extent, the NHR budget has been ring-fenced.
Yeah.
Now, that's for now, and we all know that the politicians change their mind very quickly, so who knows what will happen, but it looks increasingly likely that NHR budgets will be protected, at least in the medium term, in a way that, frankly, the rest of the public sector is in for a very, very rough ride, I think, over the next few years, and already is. So I think it's not going to be that we're getting more money necessarily in the medium term, but I think it'll be protected. The big problem for us in trauma and orthopedics trying to liberate money from a relatively small group of funders, or one essentially, is that the other areas of research, I'm thinking of cancer and cardiovascular and stuff, which traditionally used, the major funders were actually the Cancer Research UK and British Heart Foundation and so on. So not the NHR. They've been absolutely decimated because all their, charitable activities have been curtailed by COVID, and their funding's disappeared. So what you're finding is that on the NHR funding boards now, we're seeing many more applications from researchers, very high quality researchers across different fields who never applied or didn't apply very often to NHR, and now just going to NHR because there's no money at CI UK or so. And so the competition level at the board is now frightening. I mean, the quality of the applications is incredibly high, and therefore the bar to get funded has been set even higher. So I think it's tough times. I mean, the only response to that is to put in top quality applications, and as ever, a small number of very high quality applications from the community in trauma and orthopedics is better than a large number of not quite nailed down. Because frankly, if the actual protocol you're submitting is not completely nailed down, it doesn't get a look in at the moment. So mixed up. Good news about the NHR in terms of the funding, and the clinical research network that goes with that as well has been protected to a large degree. But I think competition ratios have never been higher.
Yeah, that's interesting. But like you say, I suppose you've just got to raise the bar in terms of keep the bar high in what we're doing, and small, less but very robust trials that we put forward to them in terms of keeping that level high. And that sort of leads us very nicely, actually, Matt, into our highlight papers. And I think you can see from these three papers you've picked, actually, the both the high quality and the wide range of methodology we're now publishing in the journal in this area. And I thought we'd start off with the RCT led out of Oxford by yourself and Xavier, and that was looking at the effect of the X-Bolt dynamic plating system against the more routine sliding hip screw for fixation of trochanteric fractures. And that was White 4 in the series of White platform studies, and it was a multi-center, multi-surgeon, parallel randomized controlled trial, 10 acute hospitals in the UK, and there was over 1,128 patients randomized between the two groups. And so what made you pick this study, Matt? Obviously, I mean, its size and the methodological quality are really without question, but what made you pick this?
Sure. Well, I wanted to pick out papers from different methodological sort of point of view. I mean, in general terms, one of the changes at the journal has been the increase in the number of randomized controlled trials that we're now seeing. I mean, 10 years ago when I first started, it was actually, it was a real surprise to get one through. And most of the comparative intervention studies we saw were non-randomized studies, were comparative case series and so on, and which were fine. And a lot of those, inform clinical practice, but actually the power of randomization takes the evidence base to a different level. So we're really pleased to see these things. The reason I picked out Xavier's paper, and this was very much Xavier Griffin's study, I was just sort of supporting it, was because of the new technology and the way it was tested. So it's a good quality RCT with good numbers, and it's a nice methodological piece of work to have in the Bone and Joint Journal. So from a methods point of view, we're very pleased in the journal to see work of this sort of level coming in. But the reason I picked this one out is because it was testing a new technology, and it brings up this question of how do we introduce new technology into trauma surgery in this case, and how do we test it? And many of the listeners will be familiar with the IDEAL framework, which was put forward, I think, 10 years ago now, as a method really for introducing new technology, but has not been really particularly widely adopted yet by many areas, certainly in trauma and orthopedics, for introducing new technology. This is just a sequence of studies that you do before rolling out an intervention into the whole of the NHS, or indeed worldwide. And the White 4 trial was really the final step in that chain of a series of studies at Xavier leading to a full pragmatic multi-center RCT. And this is just a step forward. And it basically showed that the X-Bolt device, which was the new intervention for extracapsular fractures of the hip, was produced very similar results to the slide and hip screw, at least as good at, and the rate of failure of the intervention is actually very similar as well. And so you've now got really strong evidence that this device is as good as, not necessarily better, unfortunately, but as good as the existing technology, and therefore it's a viable option for some people if they want to choose this device. And you just think, well, how many times have we got other devices that suddenly appear on the shelf and people start to use that have never been tested in this rigorous way, and we don't really know what the outcomes are? And of course, all of the listeners will be familiar with the disaster stories about devices that perhaps should have been tested a bit more rigorously that ended up causing patients a great deal of harm. Obviously, I'm thinking of things like metal on metal, and outside of trauma orthopedics, the silicone implants and the meshes and all of the other devices that have caused huge amounts of distress for patients over a long period. So I think this was just a great example of a study that was a culmination of a way of introducing a device to the market that's actually a sensible and safe way of doing it. And great credit to the X-Bolt team who actually supported the trial for investing their money in a proper test of their device.
No, absolutely, and I think that's right, isn't it? It's not only the safe way to assess it for patient safety, which is obviously the primary point, but also I suppose another issue with all these new devices, they often cost quite a bit of money, and we shouldn't really be using them with the finite resources we have without the real evidence. I mean, I think that's a fair comment.
I do, and as you know, we often. It's interesting. Some journals like to publish the health economic data, the resource use data associated with trials in the same paper. Other journals less so. American journals really don't want to know. It's very interesting, just a very different perspective on what things cost. They just want to know the clinical outcomes. But and the idea that cost is not important, even in somewhere like the States, is frankly ridiculous, because there's never enough money to go around, even if you've got you're spending twice as much of your GDP on healthcare as the UK, as they do in the US. So I think it's a slightly, from my perspective, a slightly naive view that cost isn't important. Of course it is in every healthcare system. But in the UK, obviously with our National Healthcare Service, we're acutely aware of the importance of cost, because frankly, if it's not cost effective, it won't get commissioned and we can't use it. So you're right. I think that's the other important element of testing these things properly.
Yeah, no, absolutely. So Matt, if we move on from that's a great overview of that paper. This is I thought we'd move on to the NHFD paper, which was sort of based out of King's College London, but a sort of a big data study room thing. And this was looking at data from more than 126,000 patients. And the aim was to sort of look at the effect of early mobilization, which they defined as mobilizing on the day of surgery or the day after, and late mobilization, so day 2 or more, on 30-day mortality rates after hip fracture, and also looking at how that interacted with dementia. And so this is a different type of methodology, but again, very robust given just the size of it alone, really, isn't it, Matt?
It is, and that's exactly why I picked this one out, really, Andrew. So a really nice bit of work from Katie Sheehan, who is a physiotherapist, academic physio down at King's, who's published a lot in this area, and her colleagues at King's College. And it's just a really nice example of the use of big data and how it can be used to inform really important questions for sort of patients. And this is what we're seeing now. We had I think we were all a bit nervous about a lot of the routine data studies. I guess the registry is not strictly speaking routine data, but big data sets anyway, about how to interpret them, because you get hugely statistically significant results that are probably clinically meaningless. If you put enough numbers into the equations, then essentially you'll find differences that frankly no one cares about. So interpreting these studies has been tricky, and I think we're all learning. One of the things I liked about this paper, as well as a really clinically useful message, I mean, one of the problems with big data is that you often end up answering questions that you can answer rather than the ones that are necessarily the most interesting, because you're limited by what's in the data set. Yeah. Whereas I think this was something that really, does make an impact upon patient care. But the other reason I picked it out was because it shows, if you look at the list of authors, there's some very senior academic therapists on there, which is quite right. They should be, leading studies in this area. But there's also some fairly hardcore statisticians in there as well. And I think that's the combination you need for these large data sets. These analyses are not straightforward. And, for people like yourself and me who are interested in this area, we have some understanding of statistics, but I'm not pretending to know the nuances of how to interpret this data set. And even the most clued up clinicians will struggle, I think, to interpret some of this data and, to know how to build the correct models to look at these. So having some very experienced epidemiologists and statisticians involved is key. And I think this paper exemplifies the value of that That's not to say there isn't unknown confounding within this data set, but the limitations of the data are on display, and the authors make those limitations clear. And I think there's still a useful message here about the value of early mobilization for patients.
Yeah, I think that was interesting as well. Like when I, reading it as well, they're very clear about what they haven't covered in confounding variables, and they're very honest about that. And I think that's almost it's a sort of a neutral view, isn't it? As a statistician, you don't really care about. You just got the data in front of you. You've not really got a bias, I suppose, from a clinical standpoint, which is a very useful thing. The other thing I thought it sort of linked in nicely in terms of, which we've discussed previously in a podcast, this sort of from the white group data, the best practice tariff indicators and how they affect. And actually this sort of links in nicely in terms of, should this be an indicator in early mobilization? Because obviously, and this is how it can all build from this big data, can't it?
It can. And the paper you mentioned, the White paper about best practice tariff, really showing, well, for the first time in a big way, that actually quality indicators of care, things like, early surgery and the geriatric review and early mobilization did make a difference to quality of life as well as mortality. And, that's really, really important. Ironically, just at a time when the government's considering scrapping best practice tariff, we've produced fairly hardcore evidence it makes a big difference. So it's a bit of a shame, but that's politics for you.
Absolutely.
But I think, these papers, doing them well is really important. And it's great. That's what, as a reviewer and as a specialty editor, that's what I want to see. I don't care that there's problems with the data. There's always problems with the data. No study gets complete follow-up. No study, everyone gets the right treatment that they're meant to have. And that's part of, the game and part of life, isn't it? But what I want to see is a full and, as you say, a quite objective assessment of that data, which I think is what the authors do here. And that reassures me that they are, telling us the full truth, if you like, or at least as close as, in the fact that they're, presenting their data warts and all. And that's what I want to see when I'm looking as a specialty editor at a paper like this.
Yeah, that's really interesting. So if we just move on to the final highlight paper, Matt, that's from the OTS group, and that sort of looked at their proposed new open fracture classification system and sort of how this correlated with patient-centered outcomes. And that was using data from 2 large UK trials that she led on Wist and Wolf. And it was this study, which was accompanied by a great editorial too, which sort of looked at the history of open fracture classification and how it's evolved over time, and potentially the limitations of, I suppose, the most classic one we use is the Castillo one. And this study used data from 748 patients, and the outcomes that they looked at were sort of DRI, EQ5D, sort of health-related quality of life data, as well as deep infection at 30 days. And it's sort of a nice study in terms of looking at not only proposing a new fracture classification system, but also how that correlates with patient outcome and what the patients actually feel. So Matt, I suppose, could you sort of briefly describe why you picked this paper and why you felt it was important?
Sure. Well, I think partly because this was something a bit different. And, we always say at the journal that we don't really care what the methodology is, as long as it's the best methodology to answer that question. So because of the sort of work I do, I occasionally get people at meetings tell me, well, you only consider RCTs for the journal. And don't get me wrong, we like RCTs. They're high quality evidence for interventions, but most questions actually can't be answered with RCT. And even many that could be probably shouldn't be because of the expense and the infrastructure required. So I don't think RCT is the answer, which is why we like, some good quality observational data as well. And, if you're looking at diagnostic testing, we want those papers as well. And this is just something a bit different that I thought, well, actually, if you get the methods right, there's no randomized trial data in here. The observational data from the trials is used, but this is, just about validation of a classification system or a step in the validation process. And so this was Alex Trompeter's work, and really reflecting just a long-standing view between many of us working in the field that we still can't objectively classify these fractures. And so Alex had been thinking about this and trying to work out how we could produce a more objective classification system. And so the other thing, the reason I picked the study is because of the quality of the data that comes from the trial. So you can answer the trial question in terms of what's the difference between, the different interventions in the trial. But actually, if you just follow the patients up in the longer term, you also get these fantastic observational data sets with complete follow-up because of resources that you can use to follow the patients up. And so we were able to do that in this case. And for the first time, really correlate a classification with the patient's view of outcome, the patient's reported health-related quality of life and disability. Whereas the previous classifications have really been raised around, well, can you salvage the limb? Which is an important question, but maybe not the most important, for most patients don't lose their limb, even after severe open fractures. And also around infection, which although again, obviously an important outcome, it is not necessarily the most important one. So you can have a deep infection, but if that's treated aggressively early on and you get eradication, that patient can have, essentially as good an outcome as other patients without infection. Whereas the ones that cause a real problem, the ones that you don't get on top of and they end up with chronic osteomyelitis and so on. So just having the infection doesn't necessarily predict your outcome. And equally, there are many patients who don't have infection that have a very poor outcome due to only healing problems, or more commonly even soft tissue problems. And as we published on recently, chronic pain is such a massive issue after these severe limb fractures that I'm probably under-recognised. So lots of reasons for picking Morris out. A different study design, different type of methodology, hopefully a useful contribution to literature in terms of reducing the subjectivity of the classification, but also the benefits of these large data sets that to look at these and use them for answering other questions, not just the ones that you set out in the randomized trial design.
I agree. It's a really interesting use of that sort of secondary use of RCT data. Do you think we do enough of that? I know it's because all that effort goes into that trial. Do you think we could do more of the secondary uses? And now it's been often led by yourself in many of them, really good RCTs. Should we be using them more for secondary analysis? Do you think that's a good thing to do, or do we have to be careful?
I think, yes, we should do. And, Mo Bandari and the group from McMaster have done some really nice work looking at some very large trial data sets and, answering questions or proposing questions based on those data sets. So I think it is increasingly happening, and we should use these data sets more because, most of these studies take millions of pounds of taxpayers' money. To not extract maximum information from them is a travesty, really. We shouldn't be allowed to get away with it. The thing that everyone's got to remember, and that, even as someone who does this sort of work, I have to remember, is that you're basically then dealing with an observational data set.
Yeah.
So you're taking the data that you have and trying to extract information from it in a way that you could from a registry or routine data. You're not collecting the data specifically. You didn't collect the data to answer that particular question. So essentially, all of these studies are hypothesis generating. They can propose new questions and give some evidence of association, but what they can't do is provide causality here. Sometimes because you've got high quality data, the tendency is to overinterpret it. So again, when looking at these secondary analysis papers, I take the view of, well, this is now an observational data set. Yeah. So all the caveats with that, as we discussed with the National Hip Fracture Database paper, then they apply equally to these secondary analysis papers as well. So yes, some caution, but yes, we should certainly be using these high quality data sets.
It's sort of, and just sort of final question on that, I think it's interesting, is it because one of the great advantages of those two studies was that they had the similar outcome measures at the similar times, and it would be almost useful. I know you can never dictate to people, but actually having standardized outcomes at standardized times would be very helpful for when people do trials in the same area, so you could actually combine them more easily in some way.
Oh, totally. And developing core outcome sets. So in particular areas for particular patients with, in our case, particular injuries, it is invaluable. And as you know, there's a lot of work gone on in that. And actually, Steve Gwilym wrote recently in the BJJ a very nice editorial about the importance of engaging patients in deciding what priorities are for research and also for developing these core outcome sets from a patient perspective. Because frankly, we've always measured X-rays and infection rates because we're fascinated by them, but from the patient's perspective, they want to know about their quality of life and disability. So, that's why developing patient-centered core outcome sets to allow comparison between studies and to allow evidence synthesis, because, meta-analysis is easy if you've got the same outcome measures, but how often do the same studies, different studies in the same population use different outcome measures, or even the same outcome measures at different time points? And how do you combine those? It's a very difficult problem.
Yeah, no, absolutely. So that was a great overview of those three highlight papers, Matt, and like I say, really great choice in terms of their breadth and of the methodology in particular. So just to finish up, what do you think are the sort of key questions? I mean, we've touched on it already, but in sort of trauma, what are our key questions moving forward? Do you think where are we going to go over the next few years?
Well, the really good news is there's some really good quality trials going on in the UK at the moment, and spread around the country with a lot of new lead investigators, which is just brilliant news for the profession, I think. And to particularly to have a larger group of people involved. I think with last count, we had 140 of the 170 acute care hospitals actively engaged in recruiting into trials now in the UK, which is just amazing. So I think that's really exciting for those trials. I think we're getting better and better routine data, registry data papers coming through, and the analysis is getting more and more consistent and better described. So that's really exciting. I think what we'd like to see is some more papers. I think a global health perspective would be fascinating to journal, and we try and do this, and it's not always straightforward, but we're actively encouraging and getting increasing numbers of submissions from other parts of the world, and particularly in low middle income countries where there's such variable care with regard to trauma, and it's such an under-recognised problem that I think that would be nice to see more data coming from those settings, which I think would be fascinating for us here, and also potentially hugely helpful for patients in these countries with less well-funded economic healthcare systems.
Absolutely, Matt. No, I agree. Well, I think that's all we have time for, Matt. But thanks so much. That was a really excellent and really informative overview of the trauma specialty area over the past year. And as always, it's great to talk to you. So thanks for joining us, Matt.
Great. Thanks, Andrew.
And to our listeners, we do hope you've enjoyed joining us. Feel free to tweet or post about anything we have discussed here today. Thanks for listening, everyone, and take care.